Welcome to our Heart Health Lecture Series. Welcome back after the summer recess. I'm delighted to be able to start up again, and we have a fantastic speaker for today, whom I will introduce shortly. Next slide. So you all know who I am by now. I'm Dr. Dennis Goodman, and I'm a clinical professor in the Department of Medicine and Cardiology at NYU. I'm Director of Integrative Medicine, and it is my pleasure to have founded this series. And I just want to express my gratitude to Anya Coates, who's been an amazing partner with me as we put this series on and do our very best to educate people out there about prevention and how important it is. Next slide. So we've had this series since 2015. We've had over 60 lectures. And as you can see, many of the topics have been actually repeated because we keep coming back to the same old diseases that we need to be thinking about and how to prevent them. And so you see this list here. We've covered sleep, diabetes, cholesterol, blood pressure, thyroid, inflammation, hormone therapy. Next slide. And what I try to focus on are what I call the four legs of the stool, which are so important for prevention. And they are nutrition, exercise and flexibility, sleep and stress management. And I have a fifth one, which is socialization and connection with other people, which is such an important part of being well. This is all about how can you be well? You know, there's a saying that that wellness is not the absence of disease. And it's so important to take care of yourself so that you can be well, because you can go to the doctor who can't find anything wrong with you because we do tests and nothing shows up, but you're not well until you take care of all these five legs of the stool. Next slide. So we have a library now of most of the talks are on YouTube, and we've had over 93,000 hits so far. So I'll give you the address in a minute on how to get to our NYU Langone YouTube channel. Or you want to repeat them or hear them again, you can go to our YouTube lecture library. Next slide. So our upcoming webinars are on Tuesday, November 14th, migraine, heart disease, and stroke. We're going to talk all about migraine headaches in relation to the cardiovascular system. We have Dr. Mouskop, who is a wonderful speaker and an absolute expert and very holistic and integrative as well. And then on Wednesday, December 13th, we're doing dementia and the cardiovascular system. So please put those. Next slide. So how can you be in touch with us? This is the web address that you want to know, nyulangone.org/hearthealthlectures. And you can find out what's coming up, and you can get the link to the YouTube lecture series. Everything you need to know about our series and what we're doing is on this website. Next slide. I just gave you the website address. There's other ways that you can be in touch with us: email and Instagram. Next slide. So while we're talking today is going to be more of a Q&A. I'm going to be asking Professor Slater, Dr. Slater questions. We're going to discuss palpitations and everything you want to know about arrhythmias. And if you have a question, please put it into the QA box. And I'll be monitoring the questions along the way. And I'll ask Dr. Slater as many of the questions as possible. Next slide. So today, the topic is palpitation. I couldn't have found a better person and physician to talk about this. Dr. Slater, I'm sure you'll agree with me that this is the bread and butter of cardiology. And we see, I'm sure over the years, you've been around for a long time, you've seen thousands of patients who come with palpitations. And that's what we're going to discuss today. Next slide. So our speaker today is Dr. Professor William Slater, who is in the Department of Medicine and Cardiology at the NYU Grossman School of Medicine. He's a clinical educator. He's director of the Cardiology Consult Service at Bellevue. I have to take this opportunity of telling him how honored I am that you agreed to come and speak to us. You are actually one of my heroes. You are a real doctor. I want to say a few words about your background. You went to medical school at Harvard. You did internal medicine at NYU. You did cardiology at Mount Sinai, and then you went back for an electrophysiology or an arrhythmia fellowship at the Brigham and MGH, which is Harvard. And then you came back to NYU and you've been here ever since. I know you practice general cardiology and with a focus on arrhythmia management. I read that you chose medicine because when you were a teenager, your mother had breast cancer, and you realized how important it is. The words of a physician and what a physician says and how they talk to a family can make such an impact, and that inspired you to become a doctor. I know that your emphasis is on compassionate care, and you know that that's at the core of healing. I know that's what you believe. You integrate the physical and emotional well-being of patients, and to be honest, I call that integrative cardiology, which is near and dear to my heart. You're a great educator and healer. Dr. Slater has received numerous teaching awards. He's been the Teacher of the Year at NYU several times, both in the Department of Medicine and Cardiology. And he received the NYU Distinguished Teaching Award in 2007, which is the highest award that can be given at NYU for being a teacher and educator. He received the Alpha Omega Alpha Award in recognition of excellence in scholarship and leadership and service. He received Gold Foundation Award in 2000 from graduating was awarded to him. He's been honored consistently by his peers as well. He's been in the New York Times and in the New York Magazine for many, many years, and also the U.S. News and World Report and always featured as one of America's and New York's best and top doctors. He's written many articles on clinical cardiology and book chapters, and he's a reviewer for the Journal of the American College of Cardiology. In short, Dr. Slater, in my opinion, is the consummate physician. Bill, I think of you as a colleague, and I think of you as a real healer, an educator, and a human being. And many of you all know this word, a real mensch. So it is a great honor and privilege to be a colleague of yours at NYU. And I think that you've inspired thousands of medical students, thousands of doctors, because of your humanism and your incredible passion for helping to teach the next generation and to make sure that people come out better doctors, better healers, and better caregivers. So with that introduction, Bill, I'm going to say, maybe you can just say a few words. Great. And then we're going to ask some questions. I think that's how we're going to do this today. Right. But I'd like you to just start off, and we can go to the first slide.
So I'm now convinced that Dennis will do my eulogy, and I appreciate that. He is one of my heroes as well, and we go back a long ways, and Dennis has really brought integrative cardiology at NYU and lectures to our students and exposes them to the whole realm of integrative medicine, which a lot of schools don't do. So Dennis is a great blessing for us. So, I think the best way to do this is really in a very open forum. So palpitations are a very common symptom. They're a very emotionally loaded symptom, although most of the time they're quite harmless. So I thought we would do it more as a question and answer format rather than a kind of lecture format. So please feel free to send in your questions. We'll try to keep it very open and very informal. So what are palpitations? Palpitations are a description of the patient's experience. So palpitations can reflect the normal rhythm. So I get palpitations if I have too much coffee or if I'm emotionally stressed, but that's normal. So my sensation of palpitations reflects just the response to my adrenaline being revved up. So a pretty good guide is that if it's a subjective sense of a regular boom, 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 and I take my pulse and I check it with a watch, and my pulse is regular and my rate is under 130 or 140, and it occurs in settings of caffeine or emotional stress or dehydration or excessive alcohol, these are highly likely to be just adrenaline-related things. When do you need to see a cardiologist? I think the underlying theme in this, and we're going to focus mainly on healthy people who have subjective symptoms of some irregularity or some awareness of their heartbeat, but dangerous rhythms really occur in people with heart disease. So that's sort of the sine qua non of this. If you were young and healthy and what you're experiencing is subjective skipped beats or missed beats or a sense of an awareness of your heartbeat, you're highly likely to be fine. Dangerous rhythms occur in people with heart disease. So when do you need to see a cardiologist? I would say if there is any suspicion based on your age, your coexisting illnesses, or if the palpitations are significant enough to make you lightheaded or fainting. The rhythm that we are mainly concerned about in fairly healthy people is atrial fibrillation, which carries a concomitant risk of stroke, and that is a randomly irregular rapid beat. So if my palpitations are single skip beats or single extra beats, those are highly likely to be the ups and downs of biorhythms of adrenaline, just like my hands might be colder 1 minute, my skin might be more flushed 1 minute, my bowels might be looser one day versus the next. So isolated skip beats are generally quite harmless. A rapid, irregular cadence probably warrants an exam by a cardiologist, and a suspicion of structural heart disease if there's an association with shortness of breath or an association with lightheadedness or dizziness, then I think cardiology evaluation or primary care evaluation is probably a good way to start. A lot of healthy arrhythmias are really a reflection of what I call biorhythms. And the best example of that to me is the menstrual cycle. So if you say, well, if a young woman says, why do I have my period every 30 days? Well, these are intrinsic biorhythms, the ebb and flow of life. Adrenaline, which is the main chemical or hormone that governs symptomatic palpitations, adrenaline has the same biorhythms. So adrenaline, its biorhythm is not every 30 days, it's up and down through the day. So my hands might be colder at 8 a.m. and warmer at 9 a.m. and colder at 10 a.m. Likewise, my skin might be more flushed 1 hour, less the next, more the next. My bowels might be looser, different. So these are biorhythms. And it sounds kind of silly, but adrenaline sort of goes up and down through the day. Every person is like a car engine, and we function differently through life. Week by week, month by month, our engine differs. So if I'm in a phase of life where everything's going well and I'm relaxed and I'm not stressed, I function like I have a 20-year-old car. That's how I function. If my life is more stressful, I function more like a Maserati. So if I'm functioning like an old jalopy, my adrenaline goes like this. If I'm functioning like a Maserati, and these are different phases of life, my adrenaline goes like this. And everyone is sensitive to that in their own way. And that sounds like a dumbed down, silly version, but it's really very true. So if my adrenaline, instead of going like this, is going like this, depending on how I'm wired, I might get cold hands, I might get goosebumps, I might get flushed, I might get looser bowels, or I might get a series of different rhythm disorders. So things that rev up adrenaline will foster palpitations that can be caffeine, can be alcohol, can be dehydration, can be stress, can be anything that turns your engine, that turns you from a Hyundai to a Maserati. That sounds silly, but that's really true. And I think that's a useful analogy in many ways, because people will often say, well, yeah, I'm getting my palpitations now. And okay, I get it. I'm under more work stress or more relationship stress or more whatever. My life is a little more tumultuous. But when I get my arrhythmia, I'm not under any perceptible stress that moment. And the analogy that I think is useful is the analogy of irritable bowel, or the analogy of a nervous stomach, where if the way I manifest my revved up biorhythms is through my stomach, and before a flare of a nervous stomach, you can always show that your engine is more revvy. But it's not like every time I'm in the bathroom am I under perceptible stress the 2 minutes before. But in a phase of life where my engine is more revvy, my adrenaline, instead of going like this, goes like this. And if I manifest it through my bowels, I'll get irritable bowel. If I manifest it through my skin, I'll get goosebumps or, flushed or cold hands. If I manifest it through my heart, I'll get a boom, 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 or I'll get extra beats, or I'll get an accelerated beat. So a lot of healthy people palpitations are simply related to the biorhythms of life. So in terms of, when does that warrant attention? I think it warrants attention if one becomes lightheaded with symptoms, if they're random, irregular beats, if they're sudden, very rapid beats. Those are situations where I might seek advice. How do I prevent palpitations? Hard to entirely prevent them, like it's hard to prevent irritable bowel. It's doing things that can turn your engine down. So that means meditation, that means exercise, that means adequate sleep, that might mean things like CBD, which can help, means yoga. It means doing whatever you can do lifestyle-wise to turn your engine down. And it sounds very silly, but the goal is to be as much an old jalopy engine-wise rather than a Maserati. If the goal is to prevent palpitations, that sounds like a silly model, but it's a very valid model to me.
So, Dr. Slater, I just thought I'd put that into a little bit of scientific terms, in terms of what are we doing? We're trying, you mentioned adrenaline, and that's really the sympathetic nervous system in overdrive. And all these other modalities that we talk about are really to try to stimulate your parasympathetic nervous system, which slows the heart rate down, calms things down, cools things down. And I think that's so important. These techniques that you spoke about, especially, exercise, meditation, yoga, help to stimulate the parasympathetic nervous system. And that's really important that you focus on that and not just say, well, there's nothing we can do, because you really can turn down the sympathetic system when you stimulate the parasympathetic nervous system. Can you hear me well? I know there was a bit of a problem with the connection. Can you hear me, Dr. Slater?
I can hear you perfectly, Dan. Yes.
I thought that just because it's such a common thing that we see people coming in with palpitations, which you've emphasized is a subjective sensation, of something you're feeling your own heartbeat essentially. And sometimes it's forceful, and sometimes it feels like a skip, and sometimes it feels irregular. A lot of times people feel palpitations and we actually don't find anything irregular. They're just aware of their heartbeat because, as you said, they revved up. I just want to ask you, so when patients come see us, what do you do in terms of a workup initially to try to evaluate? Because you made this very good point. They're really only a problem if it's associated with underlying heart disease. So what kind of tests would you do initially in your office or order to help determine whether or not these palpitations are of concern?
Right. So that's a great question, and again, the underlying kind of philosophy is that if you have a healthy heart, your arrhythmias are highly likely to be innocent and more engine, what I call engine related, and what you articulately call sympathetic nervous system related. So I think with high confidence, a normal exam and a normal electrocardiogram in an otherwise healthy person probably constitutes an adequate workup in a patient with no other symptoms. So if you're young or middle-aged and can exercise fine, no shortness of breath, no swelling, no dizziness, and your only symptom is some palpitation that is not, again, the suspicion of atrial fibrillation being very rapid, irregular beats. If your symptom is a regular, more rapid beat, skipped beats, extra beats, the main workup is an exam and an EKG. If you are concerned or your physician is concerned, a sonogram of the heart, an echocardiogram is probably the sine qua non, the ideal test to get. And if that's normal with exceedingly high likelihoods, you have a healthy heart. One thing that comes up a lot is people have a sensation of skipped beats. I think if we have extra beats, that intuitively means, well, there's an extra beat. But when we feel missed beats, we sometimes say, well, is that a problem with the heart stopping? But missed beats are a reflection of an extra beat. If my heart suddenly just misses a beat, I might feel a little lightheaded, but I'm not going to be aware of that because you don't feel your heartbeat. Right? So if I'm sitting here, I'm not aware of my heart. If it suddenly pauses, I won't feel that. But if I have extra beats, very often the extra beat comes early. And there's not enough blood in the heart yet to generate an output. So I don't feel that beat. That's kind of like a mystery beat. But the heart is very smart. It has what's called a compensatory pause. So if I have an extra beat, that beat comes early, I'm often not aware of that because there's not enough blood in the heart, but then there's a pause. And the next beat has a lot of time to fill. So sometimes people will say, I feel like my heart is skipping a beat. But the awareness of skip beats really comes from an extra beat. So extra beat and skip beat, paradoxically, is the same mechanism. It's all an extra beat and then an adaptive compensatory pause, the wisdom of the heart, so there are not too many beats a minute. So skip beats and extra beats, same mechanism, usually harmless, single extra beats, usually coming from the ups and downs of adrenaline. So in terms of workup, I hope I answered that.
Yeah, I would just add one thing, because I know we do this all the time, which is many times we're trying to find out, what is the palpitation? Is it associated with an arrhythmia, an irregular rhythm that we need to be concerned about? And we use something called a Holter monitor or a cardiac event monitor, where we can actually record a person's rhythm for 24 hours or 48 hours on their event monitors, where you can actually hook something to your chest and we can actually connect with an outside center where they're monitoring every heartbeat. You can press a little button and it'll indicate you're actually feeling the palpitation. And I'm sure many patients, because they are right on their monitor, on their record pad or paper, I'm feeling palpitations. And then when I go look at that time, they're not really, there's no arrhythmia, or there's something completely benign. And I think that's very reassuring to say you're feeling your own heartbeat, which is a normal heartbeat.
Yeah.
And there's no need for concern, because when people feel palpitations, they get very anxious. It's just what you said. They feel, is my heart stopping? Is there something going to happen to me? And I think reassuring people that this is a normal rhythm. You may be sensing something, but it's completely normal and nothing to worry about, is a big part of how we treat people.
No, I think that's a great point. And I think the point you're making is that people get very, very nervous. The thing about arrhythmias is they're so unpredictable. So people will, and again, this analogy of
right.
irritable bowel, where people say, well, okay, you're telling me that this is harmless and related to the ups and downs of biorhythms, but but I wasn't stressed. I wasn't doing anything differently when my heart started to beat irregularly. But it's really the model of the menstrual cycle. These are intrinsic biorhythms. And this is the ebb and flow of life. So if your engine's a little more revvy, and again, that comes in phases of life, it's all adrenaline. Instead of going like this, it's going like this. So there's not perceptible stress most of the time before these things occur. But Dennis is really pointing out the value of monitoring. Technology, has become so good. So we've had what Dennis describes as a Holter monitor, which is just a continual multiple wires that have been around for 40 years that you wear for 24 or 48 hours. And that's fine technology. A lot of it has been supplanted by much smaller devices that look like a Band-Aid that one wears on one's chest. That can have active telemetry to alert a recording station if you have a symptomatic arrhythmia where you press a button, or any dangerous arrhythmia. There are algorithms that imply some risky things. And so if you wear a little monitor for 2 to 4 weeks, you can get active telemetry. You can record these things. They're little computer chips you can insert under the skin. There are a lot of great technologies. One very good technology is a little device called the Kardia device, Kardia. It's a company called Kardia Mobile. I'm not advocating one particular company, but it's a good little device where it's an app that you load on your phone, runs around $60, $80. And it's an app that is linked to a little strip. And if I have a symptom, let's say I say, oh, gee, here's my pesky rhythm thing that I've never been able to record. I'm going to put 2 fingers on the recording strip, and it records for 30 seconds, and it's linked to an app. The app will actually tell you what the rhythm is, but most people are not, cardiologists, but it allows you to put in your doctor's email. And so when you record it, you just hit the button and it emails the strip. I get every day, at least 5 or 6 of those recordings from patients who are experiencing symptoms and want to correlate that with their heart rhythm. So as Dennis points out, the monitoring technology has become really very sophisticated. So it's very rare that people have symptoms that you can't correlate with a heart rhythm. And as Dennis points out, that can be very reassuring, as well as very medically clarifying.
Okay, let's take some more questions. We've got some slides with other questions, and then I've got several questions from our audience, from our participants. So we do need to talk about this because this is a rhythm that's important to know about. And maybe you can just tell us, what is atrial fibrillation? Why do we have to worry about it? And how do we diagnose it?
So the great question. So atrial fibrillation, the heart has 2 upper chambers called the atria and 2 main pumps called the ventricles. And they typically contract in sequence. Atrial fibrillation is some short circuits that occur in the upper chamber. So let's say the heartbeat is initiated by a battery at the top. It's called the sinus node. It's a battery. Every time that battery fires, it sends electrical signals through they're like wires, electrical wires that go through the upper chambers, the atria, and then through the lower chambers. And as the electricity goes through each chamber, that chamber contracts, and that's how blood is pumped out. So let's say in the circuitry in the upper chamber, let's say I have some condition that alters my upper chamber. My upper chamber is enlarged from some aspect of heart disease, high blood pressure, valve disease, heart muscle disease. I have a weak or a thick muscle. Anything that causes the upper chamber to be stretched changes the way electricity flows through the upper chamber. And let's say the electricity flows faster through one fiber than its neighbor. When the electricity gets to the bottom, it says, you know what, instead of going straight down, I'm going to go backwards. And it starts an electrical short circuit. And atrial fibrillation is multiple little short circuits in the upper chamber. The manifestation of atrial fibrillation is it tends to make the heart beat faster and irregularly because it's governed by those short circuits rather than the normal battery. And when the upper chamber fibrillates, there's stasis of blood flow in the upper chamber and some risk of clot formation. Atrial fibrillation in most people comes from the upper chamber being stretched, and usually that translates into some form of heart disease. It may not be serious heart disease, but most of those folks warrant so-called blood thinner or anticoagulation to prevent clot formation. But atrial fibrillation comes in another form, and unfortunately, it has the same name. Atrial fibrillation can be one of the spectrum of adrenaline-related things. So we spoke about those upper chambers. Well, there are veins that enter the upper chambers from the lung. They're called lung veins or pulmonary veins, and they have adrenaline-sensitive spots. So we see all the time a police officer in an altercation will develop atrial fibrillation, a fireman in a stressful situation, a medical student who's sleep deprived, a stressed executive who's drinking too much. In other words, any situation where adrenaline surges, if I'm wired appropriately, there are adrenaline sensitive spots in those veins above the atrium that can put the atrium into fibrillation. That tends to be a very harmless form. We tend not to anticoagulate, we reassure. So it can be one of the spectrum of benign adrenaline-related things like irritable bowel or goosebumps or cold hands or flushing. So unfortunately, it has the same name. So the evaluation of atrial fibrillation depends on, do you have heart disease, or is this just a spectrum of one of the spectrum of adrenaline-related things? Medications are used since a lot of it is adrenaline-related. The initial treatment is usually so-called beta blockers, beta meaning adrenaline. So if I am, for example, a 60-year-old man with a history of high blood pressure, and I develop irregular palpitations, or I come into my doctor and I have an electrocardiogram that shows atrial fibrillation, the doctor will say, well, most of this is in some way triggered by adrenaline. And the doctor will generally start with beta blockers, which are modestly effective. If my symptoms persist, I have options of using anti-arrhythmic medications, which are usually effective about 70% of the time, but I have to take them every day. So a lot of people will say, well, you know, I don't want to have these symptomatic palpitations. I don't want to have atrial fibrillation. I don't want to take medication to prevent it every day. It's bothersome enough for me. So I'm going to ask about a catheter procedure called ablation, which is placing catheters and cauterizing those electrical short circuits. Tends to be very effective, long-term prevention of atrial fibrillation, somewhere in the 80–90% range. But those are the options. The judgment about anticoagulation is based on if there is heart disease and dilation of the upper chamber. Generally, one would use anticoagulation as stroke prevention. And then the second issue is prevention of symptoms. So atrial fibrillation, unfortunately, that term encompasses people with heart disease who have the short circuits because the upper chamber is stretched. But the same term is used for a 20-year-old medical or a 25-year-old medical student who is sleep deprived and stressed and has atrial fibrillation. And that's a very different condition. The success rate of ablation it depends on how extensive your heart disease is, but it's generally somewhere in the 80–90% range. And how often is one or more procedure indicated? About 15% of people from the ablation, since it's cautery of the short circuits in the upper chamber, about 15% of people unfortunately have a new circuit that is caused by the cautery. But that generally is a very simple procedure to cure with a second, very brief ablation. So it's about 15% of people that need a second ablation. One of the emerging, it's a little bit of a detail, but one of the emerging things, the problem with atrial fibrillation, and this is kind of like, I think, a key concept to understand, is if I'm a 60-year-old man and I go into my my primary care physician and I say, you know, I have irregular palpitations, but they only occur once a month. And the physician looks, does some recording when I have my symptom. It's atrial fibrillation. And the doctor says, here's an anticoagulant for you to take every day for the rest of your life. People say, well, what's this about? I know when I have my symptom. My symptom lasts for half a day or a day. Why are you giving me an anticoagulant that is in my system every day for the rest of my life? It's a terrific question. The issue is that when you have atrial fibrillation, excuse me, I'm sorry. When you have atrial fibrillation, you are aware of it if your engine is more revvy, and you tend to be unaware of it if your engine is a little less revvy. So everyone says, I know when I have it. Come on, my heart goes boom, boom, boom. You're telling me that I have it without knowing? About 80% of people have asymptomatic episodes. So if you've had atrial fibrillation resulting from some heart issue, hypertension, heart disease, valve disease, you generally warrant anticoagulation, even if you don't feel the symptoms very much of the time. Now, that philosophy is being challenged a little bit with the advent of all these monitoring devices. You do have the opportunity to put in continual monitors or check several times a day with this cardio device. There are now, there's an emerging, very large National Institute of Health sponsored trial looking at other ways of recording whether you really do have atrial fibrillation unknown to you. So it's an emerging field, but generally still warrants anticoagulation, even if you say, gee, I only feel it very rarely.
Yeah, I would just add that, many times, unfortunately, especially elderly patients will come and present with a stroke because they don't know that they've had atrial fibrillation. And we find that they've had atrial, or they're in atrial fibrillation, or they've been having atrial fibrillation. And so I can't emphasize enough that if you do have an irregular rhythm, an irregular heartbeat, you do need to see a physician, make sure you don't have atrial fibrillation. And if you do, there are specific criteria for being anticoagulated, which is crucial and so important for stroke prevention. The other thing I just wanted to say is that what we all do is when a patient presents with atrial fibrillation, we look for the underlying cause of it. Because I'm a believer that when we get to causes, it's much better than just symptomatically treating people. And many, as Dr. Slater says, sometimes it's hypertension, it's maybe underlying heart disease. It could be pericarditis, was an inflammation of the lining around the heart, sometimes associated with lung disease. So we look for underlying causes, but there's one that people often miss, and it's so important, which is sleep apnea. And so I just want to make the case that atrial fibrillation can be caused by sleep apnea, and also it's hard to treat if you continue to have sleep apnea. So our electrophysiology department refers every single patient with atrial fib to us in the prevention. Every single patient who's going to have an ablation or considered for an ablation, to our cardiologists to rule out underlying causes that could be reversible or need to be treated. I mean, it is very frustrating to do an ablation and then you land up with recurrent atrial fib because you have sleep apnea, and that's treatable. And there's ways to treat it now that are much more.
Yeah, it's a very, very good
point. We use CPAP and BiPAP in machines in severe cases.
Great point.
So I just wanted to make that point. I don't know how often you find it, but I know when I've checked, we often just do a screen and ask people if they're snoring at night, or if they wake up tired, or they're sleepy during the day. And I'm finding a lot of sleep apnea just by screening for it.
It's a very, very good point. Great point.
Okay, next slide. Thanks for that. That was a great review of atrial fib. So I've got it. I have a question that came in, and I'll just ask you that. You mentioned atrial fib, but somebody asked me about SVT. And so if you could just mention, really, if you look at it, and atrial fib is an SVT, it is irregular, it is above the ventricles. But would you just mention SVT as another
Sure. So
arrhythmia that you should know about?
It's a great question. So SVT, as Dennis says, is supraventricular, meaning above the ventricle, and tachycardia means rapid heartbeat. So there's a little structure that the electricity flows from upper chamber through a little structure called the AV node into lower chamber. And a lot of healthy people, instead of having one electrical fiber going through that AV node, have two fibers. And in response to the biorhythms of life, again, I mumbled before, if I have two adjacent electrical fibers and my electricity goes faster down one than my neighbor, when it reaches the bottom of the first, it doubles back and starts an electrical short circuit. About 1 in ballpark 8 or 10 healthy people are born, myself included actually, with two electrical fibers instead of one in that connecting structure. It's called the AV node, and it's above the ventricle. So when that short circuit occurs, people get rapid heartbeats because the short circuit becomes the battery that drives the ventricles. When we say our heart rate is high, we're really only referring to the pump, the ventricles. We don't feel anything but the ventricles. The question is, what is the so-called battery that is driving the ventricles? So, for example, I get so-called SVT about 5 times a year. My trigger is I run in the mornings. If I am sleep deprived, if I've had too much red wine and I'm out for a run, maybe 5 times a year, I will get sudden ba 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 ba. It's not atrial fibrillation. It's very regular. And if I look at an electrocardiogram or one of these monitoring devices when I have my arrhythmia, it'll be nice and regular. And it's an inborn issue. It's something that you see in young, healthy people. I give the lectures on arrhythmias, and there are about 110 kids in the class. And I ask always, how many of you guys get sudden onset of very rapid palpitations? Of the 110 kids, it's usually, 15 kids that raise their hand. So it's a common thing in healthy people. I stop mine by taking what's called a pill in the pocket. I carry a certain medicine called propranolol in my wallet and my running shorts. If I get my arrhythmia, I take one of those, and it stops it within 15 minutes. So SVT is very common. It is generally harmless. It can make you dizzy because the heart needs time to fill. So if I'm sitting at my desk or I'm out for a jog and suddenly my heartbeat starts going 200 beats a minute, it doesn't have time to fill, so the output goes down, so I can get dizzy. So an arrhythmia associated with dizziness certainly warrants clarity, because you obviously don't want to faint crossing the street or while you're driving. So dizziness warrants an evaluation, but SVT itself is harmless.
We should just say that in some patients, SVT, if they can't take the medication or the medication doesn't work, or especially if there's an underlying heart issue, that there is ablation as well, just like there is for atrial fibrillation, and it's extremely successful.
Yes.
But that would be, the vast minority of patients who have to do that.
If I got
that's always another option.
Right. If I got very dizzy when I had my episodes, I would have an ablation. but it is a harmless rhythm as long as it
Yeah.
doesn't make you faint. So Dennis is
Right, not associated.
right.
So that leads to this question. I fainted. How do I know if it's heart related? And that's a very important question.
So it's a great question, and I would say a couple of things. Fainting, if it is heart related, is almost always related to the electrical system. So patients will often say, well, I have a family history of heart disease. My dad had a heart attack when he was 46, or a brother who had a heart attack. Fainting is not related to coronary artery disease, except in very, very, very special circumstances. It's very infrequent. So a lot of people have a family history of coronary disease, heart attack, stroke at young ages. That's not related to fainting per se. Fainting is, if it's from the heart, it is 99% from an abnormal heart rhythm, not from blockages in arteries. So how do I know if it's heart related? So certainly if fainting is associated with palpitations, it absolutely needs an evaluation. You certainly need an exam and an EKG because there are certain inborn electrical abnormalities that can make you faint. A pretty good guide to harmless fainting is to ask, did my faint occur in a situation where my adrenaline would go up? And what do I mean by that? If you think of all harmless faints, they come in situations where adrenaline surges. So what do I mean by that? Think of common situations where people faint. I draw someone's blood and they faint. My daughter, first day of medical school, sees a dead body, down she goes. Somebody has pain and faints. Somebody hears terrible news and faints. Harmless faints come from a reflex where adrenaline surges and the body says, well, we're too revved up here. We have to send out anti-adrenaline, what Dennis called vagal hormones, that are anti-adrenaline. Ideally, they would perfectly balance, but the body's always counter-regulating. So adrenaline surges, anti-adrenaline says, well, I got to slow this down, but it overshoots and things slow down too much. Heart rate falls, blood pressure falls, and someone faints. So the question, if somebody has an innocent faint, is number one, do they have a warning? So if I drew someone's blood and they faint, it's not suddenly going down, they have a warning. But the question is also, was it a situation where adrenaline got revved up? And the two situations are emotional stress, which is usually pretty evident. The main thing that gets adrenaline revved up and the main trigger for harmless faints is when the volume receptors in the heart are underfilled. What do I mean by that? So as a species, the way we're wired is the main threat to us as a species was hemorrhage in the jungle from an animal bite. How does the body know that you're hemorrhaging from a leopard bite in the jungle? The heart is underfilled. So situations of weight loss, dehydration, prolonged sitting without moving around to recirculate the blood, those are the most common settings where adrenaline surges. So when someone faints, the questions I ask are, have you lost weight recently? Because if you've lost weight, you tend to lose fluid with the weight. Has your doctor prescribed a blood pressure medicine that would dilate the vessels and keep more blood in your feet and underfill the heart? Was it a situation where you were sitting in an airplane or in an opera where you're just sitting and unable to walk and recirculate the blood? So fainting, common faints tend to be in situations where the heart is underfilled. You tend to have a warning. It's with prolonged sitting. It's with dehydration. It's with weight loss. It's with starting a new medication. So those are the common situations, but certainly a sudden faint without a warning warrants evaluation. Fainting associated with palpitations certainly warrants an evaluation. fainting, if you have any form of heart disease, warrants an evaluation. And generally, it always warrants an exam and an EKG. That's sort of a sine qua non of a faint evaluation. Why does my arrhythmia occur?
Okay.
I'm sorry.
No, I thought what I would do, I know that that's the next question, but we don't have a lot of time left. I just wanted to take some of the questions from our participants.
Great.
And so one of them, we'll see if we can get through in just short answers so we can try to get as many as possible. Would you suggest buying a cardiac event monitor to monitor for atrial fib if you have palpitations, like something from Amazon? I think you answered that by saying cardia is something that's useful. Would you?
Yes, the cardia thing is, again, $50, $60, $70 allows you to make. So if you have any question of what your rhythm is, cardia device, really easy to do. Yes.
High sensitivity troponins. The question is that part of the workup for palpitations?
So high sensitivity troponin is an enzyme released from the heart, usually in response to coronary blockages. That is usually not part of the evaluation for palpitations because coronary blockages generally do not lead to symptomatic arrhythmias. It's part of the protocol in an ER, but in all honesty, the yield is trivial. And if I go to an ER with palpitations, I'm not particularly interested in getting a troponin.
Okay. One of our regulars, Stephen Ho, asks about beta blockers. Is it atenolol more dangerous than bisoprolol or carvedilol? And would you prefer any one particular beta blocker over another for an arrhythmia? And what about stopping them? Is that safe?
I think the beta blockers essentially are equivalent, and some have a little better blood pressure effects. But I think for arrhythmias, they are largely equivalent. Without getting into details, that would be my sense. Stopping beta blockers block the adrenaline receptor. The body tries to compensate by building up a few more receptors to try to compensate. So if you stop the beta blockers, you have the receptors that were originally blocked plus the extra that the body has grown to try to compensate for your actions. So you become a little super sensitive when you stop them abruptly, but it's more of a symptomatic thing, not a dangerous thing. But you generally, if you're going to stop beta blockers, do it. You taper off to minimize those symptoms.
Okay. Ernest asked about whether or not patients with atrial fib and SVT are prone to magnesium deficiency. It's a great question. I think that you should know that magnesium deficiency is associated with arrhythmias. And to be honest, in my own practice, when I've had patients with especially benign palpitations, I've found it very useful to use this cocktail of magnesium, fish oil, and CoQ10. I know that may not be commonly used in traditional medicine, but I've had many, many patients who've come back and said the heart seems to have calmed down. And when I have patients with atrial fibrillation, I'm always concerned, are they getting enough leafy green vegetables? It's very important that the electrolytes like potassium and magnesium are in the normal range, because deficiency can be associated with arrhythmias. I'm sure you'd agree with that, Bill.
I do, and Dennis, I think, has written extensively about this. But I couldn't agree more. The magnesium things that are well absorbed, and in AE, taurate, stearate, malate. But I think Dennis's point, yes, magnesium and CoQ10 can have a very salutary effect. Yes.
I actually wrote a book called Magnificent Magnesium where I went through all this. And just for people that are going to say, well, what dose? It's 1 milligram per pound for magnesium, 3 grams of an omega-3 fish oil, a good fish oil, and CoQ10, 200 milligrams a day. Another question from Stephen. What kind of arrhythmia is the result of long COVID? Are there arrhythmias associated with COVID?
So arrhythmias directly related to COVID are very infrequent. Again, anything that turns up your engine. What COVID does is it turns up your engine. It makes you more like a Maserati than a Hyundai. And therefore, your biorhythms are altered, and the adrenaline, instead of going like this, will go like this. So COVID or influenza or the direct effect of COVID, so-called COVID myocarditis, is infrequent and exceedingly infrequent in vaccinated people. Response to the vaccine, myocarditis from the vaccine, is about 1 in 100,000. So yes, certainly folks that have COVID do develop a whole spectrum of arrhythmias. It's more related to your engine being revved up rather than COVID directly impacting on your heart.
So Tracy wants to know about anticoagulation. She just wanted you to clarify, why do we anticoagulate the blood with atrial fib, and how does the anticoagulant actually work?
Yeah, so there are different anticoagulants, but they, without nerding out on it, they block the different clotting factors. And the old one was warfarin, but you need a lot of blood drawing to follow it. So the newer anticoagulants, drugs like Eliquis, Xarelto, Doxaban, they're newer drugs that don't require monitoring. They're standard doses. So the concept in atrial fibrillation is usually the upper chamber, the atrium, contracts, and synchronously the bottom chamber follows. If I have short circuits in the electrical system in the atria, when there's short circuits, mechanically the atrium fibrillates. And there's stasis of blood because the atrium is not contracting well. So that's the theory of anticoagulation. There's some details about it. There's a procedure called the Watchman procedure. If anyone's particularly interested, you can certainly Google it. Turns out most of the clots form in a little pouch off the left atrium called the left atrial appendage. There is a procedure where you can, through a catheter, ligate that, tie that off. That seems to be equally effective to anticoagulation. But that's a little bit of an evolving field. If you're interested, Google Watchman procedure. It's now commonly used for folks who cannot take anticoagulation because they have a bleeding ulcer or because they, like to ride motorcycles or things like that.
Yeah, I really like your analogy of the body getting revved up like a Maserati, because when you think about that, the causes of things that can do that, where you actually are in control of it, are things like caffeine, alcohol, some decongestant. Really important to be thinking, if you're having palpitations, what have I done or what have I taken that's revved up the cardiovascular system? There's a question about Ozempic. Is it associated with any palpitations and or arrhythmias? Is there any issue with Ozempic and the cardiovascular system?
It's a very good question. I mean, generally, Ozempic is very beneficial in many ways through its benefits on vascular disease. Inflammation goes down, triglycerides go down, so Ozempic is very beneficial for the heart. Anything that revs up your engine, so if I lose 20 pounds, the body doesn't know that I'm taking Ozempic. It can assume that I'm starving in the jungle. That's the body's response to weight loss. And so what would I want my adrenaline to do if I were foraging for food in the jungle? I would want my engine to be revved up. So weight loss can be a trigger for these arrhythmias. Again, they're generally not harmful arrhythmias. Harmful arrhythmias are in people with heart disease. So Ozempic doesn't give you heart disease, but it can rev up your engine. So it can promote these benign arrhythmias, but it is generally very worth it in terms of overall heart health.
Good. Stephen asked about open heart surgery and that you can have kidney problems. You can in certain situations. It's not the open heart surgery as such. It's in patients who have a risk of having kidney problems. It got to do with blood pressure control and what medication you're on. But he asks about atrial fibrillation. Is there any risk to the kidneys? And I'm sure the answer to that is no. And that's not something that we have to worry about. And even cardiac surgery, we know what are the risks for renal failure, and we're very careful about keeping people well hydrated and watching out for that. So I think can fibromyalgia cause palpitations? Does it affect the cardiovascular system? And
I'm sorry. I'm sorry.
Not directly.
I'm sorry. I'm sorry. I missed the question.
Does fibromyalgia
No.
Is it associated with palpitations?
No.
No. We know that that is not something that we have to worry about the cardiovascular system. So, Dr. Slater, last question, sarcoidosis. That can be associated with arrhythmias.
So
it's an unusual cause, but...
So sarcoid is a very specific condition. So sarcoidosis can affect the heart. Most people with sarcoidosis do fine. They don't have cardiac involvement. But if you have sarcoid, you need a very comprehensive heart exam because it can affect the heart, and it can affect the heart in serious ways. So it's a very specialized condition that warrants very specialized care. Most people do fine with it, but it definitely requires very real evaluation by really should be a sarcoid specialist.
There was a question about CoQ10. Is it potentially carcinogenic? And I'm not aware of that. I think it's very, very safe. Dr. Slater, professor, you are an unbelievable physician and healer and educator. You gave us a wonderful lecture and presentation, really made it simple and explained away many of the concerns that people have. If you have palpitations, you don't have to be anxious. There's very easy ways to diagnose what's causing your palpitations. And just remember, prevention, prevention, prevention. If you work on your vagal system, on the autonomic nervous system, the vagus and the parasympathetic, you'll find that you've got a lot less palpitations, and you'll be feeling a lot less anxious and feeling a lot better and a lot healthier. So thank you very much. It was wonderful to have you on, and I thank the audience, and we look forward to seeing you at our next.
Thank you, Dennis.
Yeah.